And so we are recording the webinar, just so everybody knows, and so it will be available. If you can't stay, we'll go ahead and get the slide deck out to you, and also the webinar will be available. But for those of you just joining us, again, thank you so much. This is NSI Strategies free webinar series combining MAT, medication-assisted treatment, and evidence-based practices to treat substance use disorders for all of you, for the integrated care provider. And so this webinar is for you guys. Okay, so we're going to start off with our objectives real quick. Why addressing substance use disorders in primary care is a golden opportunity, and really how we, as working in an integrated care environment, have the capacity to really change the treatment modality of addiction treatment in this country. And to truly start to treat substance use disorders as chronic health conditions and matching our treatment to what we know about the neuroscience about addiction. So we're going to talk a little bit about how to implement some of those short-term interventions to treat and address people with substance use disorders. We're going to connect that to also our patients on MAT. A lot of these skills will work for those folks that are on MAT or not. And we're going to focus in on three of the evidence-based practices: cognitive behavioral therapy, CBT, acceptance and commitment therapy, ACT, and mindfulness. And so just some quick housekeeping pieces. The recording and the slide deck, you're going to get an email link mailed to you. The link will be to a link on our website, our Integration Express archive. You can see to the right here on the slide some of our previous webinars. Again, encouraging folks in the questions and comments box on the webinar here to please put in your comments. I'll try and pay attention to that as much as I can. Sometimes I get a little lost in what we're talking about, and so I'll miss it, but please go ahead, put those in. And then at the end, when you X out of the closeout, a questionnaire will pop up. It's 3 questions. It takes 3 quick clicks. We really appreciate your feedback. And also, certainly, if you want to discuss more about what we talked about, love getting feedback or questions or inquiries from all of you out there. That's my email, or you can text or give me a call. We do love to hear from you, and any feedback is helpful. So jumping in, really what we are talking about in treating substance use disorders in primary care, in an integrated care environment, is really changing into providing care for people with substance use disorders in a new way. And so a lot of the work that we have to do is not just learning new skill sets, but also letting other folks know that, hey, you know, we have to let go a bit of some of the past. And so just turning my camera on, apologies, forgot to do that. So just letting our workforce know that we're gonna hold on to a lot of the great things that we've done to help treat people with substance use disorders, and then also shift into some new ways of treating substance use disorders. And especially in an integrated primary care environment, we have a need. We have a need to treat substance use disorders, but we also have a need for speed. We have to be able to address, diagnose, and treat the conditions that we work with in a way that's quick, it's fast, and that is adaptable to the primary care environment. And that's what we mean when we say shifting from an old way of treating substance use disorders to implementing strategies into this new way. So we really have an effective way to do this, that using short-term brief interventions is really, it's in our wheelhouse. And we know treating substance use disorders now that some treatment, any type of treatment, is better than no treatment. Again, that's the shift away from sending everyone who has a substance use disorder to specialty addiction providers. And we also know how, especially with the onset of the opioid epidemic, how dangerous detox alone can be. In fact, using having detox without offering and making available MAT medications can heavily raise the risk of death for many of our patients. And we know that rapid admission improves treatment engagement. The faster we can implement and get the care when a patient wants it, when they're ready for it, the more success we're going to have for everybody. And again, our treatment environments are built for that we can see patients very quickly. And that moves away from that older model of we know wait list time and months to get into certain treatment programs. We're shifting out of that model. And no single approach is most successful for all patients, including MAT medications. That these medications are life-saving medications. They should be made available to all patients, but we really need to focus in on individualized treatment. And that means rethinking the duration of treatment, how long we treat people, the intensity, how frequently, and the length of care. And that may range. And so adapting and bringing in that level of flexibility that we can offer in our integrated healthcare environments is not forcing patients into one treatment model or another. It's really opening up that model to offer to all of our patients based on where they're at, what they're looking for. And so that leads us to being able to treat substance use disorders for what they are. And what they are chronic health conditions. And we know the most effective, best way to treat chronic health conditions is treating across a continuum, that we treat across a continuum of care. And that, again, is stepping away from that specialty provider approach and really being able to focus along a patient where they are, moving up and down in terms of what it is that they need. And so our care, it's focused on counseling and behavioral therapies. That's something that we do for a lot of other conditions that we treat. It's person-centered and it's strengths-based, such a key approach, especially to there's no other condition that is more stigmatized than people with substance use disorders. And we are focused on interventions to enhance readiness to change, enhance engagement. That's where we come from with care for our patients. It's something we can offer to our patients with substance use disorders. And we are, in an integrated care environment, expert at combining psychosocial behavioral interventions, recovery support interventions with medications. We bring all those together. That's what we do, which is the ideal way to approach addressing substance use disorders. And we address co-occurring disorders. We know how to treat co-occurring multiple disorders that many of our patients experience at one time. So we're built to change how we treat substance use disorders. It takes our team, it takes our patient-centered healthcare approach, all the unique superpowers that we bring to the team, supporting our folks to work and treat at the top of our licenses, and knowing that we have the model to do this, that addiction is like other diseases. It's preventable, it's treatable, it changes the biology of a person, and if we don't treat it, it can last a lifetime. So our part one of this webinar series, part one, this is part two. You don't need to attend one or the other, but what we talked about in part one were specifics to the neurobiology of specifically opioid use disorder, but all substance use disorders. And in your bottom right corner of the screen is a fantastic diagram of what occurs and goes through the stages of addiction. And those three stages being binge and intoxication, withdrawal and negative affect, and preoccupation and anticipation. And we went through the neurobiology to understand why these medications make so sense, because if we understand the neurobiology of what goes on in the brain, then we can better understand why it's so critical and so important for many of our patients to be on these medications. And we talked about methadone, buprenorphine, and naltrexone as the three MAT medications, most closely associated, well, the only three associated with opioid use disorder. Some of these other medications, we know naltrexone effective for alcohol use disorder. And then many of us are using MAT even if we're not using these medications, because we use nicotine replacement therapies like the patch or nicotine gum. And when we talk about MAT, what we're talking about is really the three components of the inclusion of medications, recovery supports, and psychosocial, evidence-based psychosocial behavioral supports. And that's what we're going to focus in on today is those psychosocial supports. And again, what we're doing is we're taking a step back and we are applying what we know in our three modalities applied to what we know in the neuroscience. So let's take a look here. This is the definition of addiction. I'm going to try and get my my marker out here. And let's see if that worked. No. There we go. So what we know is addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. So what we're talking about in this first part is that this is the hijacking. This is where our patients, people with substance use disorders, these get shifted. And the dysfunction of these circuits leads to the characteristic biological, oops, I didn't mean to cross that out, I meant to underline it, biological, psychological, social, and spiritual manifestations. So we know that it impacts these areas. And it's reflected in individual pathological pursuing reward and or relief. And this is a key piece that we talked a lot about in the last component that really, I think, impacts destigmatizing substance use disorders, is that when we're talking about substance use disorders, especially severe, we're not talking about getting high anymore or feeling good. That is long past. We are talking about needing to use a drug, needing to drink alcohol for relief because of the depression, the negative experience, the withdrawal that our patients are in, and they have lost voluntary control to make healthy decisions, to make what we look at as rational decisions, and are compelled to seek out these substances. And so we know that addiction is characterized by an inability to consistently abstain. So we know that our patients, part of the criteria is that they can't abstain. They have impairment of behavior control. That it's characterized by craving, which, crazy to think, was only recently added in DSM-5. We've been practicing for years with DSM-4, where craving wasn't part of the criteria. We know what a critical component that is. And so diminished recognition of significant problems with one's own behaviors. So that means I can't see what it is that you see so clearly in me and my interpersonal relationships. I don't see it that well. And like other chronic diseases, addiction involves cycles of relapse and remission. So relapse is an opportunity for us to start to think about how we can impact and bring our patients more care, more treatment, not pushing them away. So if we talk about helping our patients and supporting them, and for many of our patients, that means reducing use or abstaining, sobriety from use. If we take and look at that substance use as a coping mechanism, we have to think about how are we going to replace it? What is it that we can do to replace what it is that substance is doing for the person? So we have to ask the question in a curious way. This is not judgmental, it's inquisitive. What is this doing for you? Why are you using? And again, it's not from a punitive parental approach of why are you using, but what is it that, despite all that's going on, this use is doing for you? Because if we start to identify that, we can start to tailor and individualize for our clients, patients, exactly what they need. So we know from the research that many of our patients have experienced trauma. And so trauma may be a component that they are experiencing. We know half the patients with a substance use disorder, and vice versa, half the patients with a mental illness have a substance use disorder. So there is comorbidity with our patients. So are we medicating and utilizing drugs and alcohol to help us manage other co-occurring disorders. Are there social issues, relationship issues? Is it a sexual issue? There are so many other components that, and I invite you to put them in the chat box, things that working with your patients, that our patients are working with, struggling with. And so for us, the work is to think about what can we do here in terms of throwing them a life vest, throwing them a support. What is it that we can do to help provide that support? So we're going to talk about 3 evidence-based toolboxes. And the 3 areas that we're going to focus on is CBT, mindfulness, and ACT, which is acceptance and commitment therapy. And the reason that I wanted to put all 3 of these together is because they borrow from each other. They each intersect. And while they have their own unique structures, they borrow very much from each other. And so I think to talk about them at the same time is so helpful. And so when we talk about cognitive behavioral therapy for today, we're also talking about relapse prevention, which is also an evidence-based practice and is part of cognitive behavioral therapy. And so for CBT, what we're talking about is teaching, encouraging, and supporting people about how to reduce and stop use. And as I talk about these, if you can, reflect back to our definition of addiction, that if our patients are not aware of their behaviors, that they are, because of what's happened in the changes in their wiring in their brain, they are going to be required us to teach, to encourage and support them to do some things that they necessarily maybe can't see or can't do. And giving them the skills to help them gain initial abstinence and recovery or reducing use. Some of our patients, it may be about reducing use. Hopefully, maybe the ultimate goal is abstinence, but that timeline is individualized and up to the patient. And building the skill set to sustain recovery, And so for relapse prevention, RP, it is a CBT treatment that focuses on the maintenance stage. And what that means is maintaining that recovery, sustaining that recovery. We're connecting those two. And it helps prevent the occurrence of a return to use. And one of the things that I'm trying to change in my language, instead of using relapse, although it's in the names of the treatments and all that sort of thing, is that return to use really moves us away from some of the negative or maybe punitive approaches that we think of relapse as a zero out, as a failure. And in fact, we've shifted away from that and really talk about relapse now as an opportunity for saying, okay, well, what do we need to add in? What's another life preserver that we need to add in? And then relapse prevention, it prevents the severity and intensity if that return to use occurs. And so if someone does return to use, can we reduce the impact that that has on that person, that person's family, and overall our community? So mindfulness. Bringing in mindfulness, it's so exciting. There's a lot of talk about mindfulness now. It's really becoming the forefront. It's gaining a lot of ground. Fortunately, it has a strong evidence base behind it. And so mindfulness establishes a sense of self that is greater than our thoughts, feelings, emotional experiences. So what we're doing is that mindfulness almost comes before cognitive behavioral therapy. It's this opportunity, it's this space that starts to help build awareness in patients, where what seems automatic, those thoughts, those behaviors, those emotions, they're not. There's a space in between that. And so mindfulness is a evidence-based practice that we can use to help build that muscle, that capacity for our patients. And so it develops the observer self that can examine those thoughts, those feelings, their body, memories, and it gives us that sense of awareness. And it's the catalyst to recognizing those thoughts. It's a way to help build that muscle to start to gain that awareness. So these are some of the core principles of acceptance and commitment therapy, ACT. So cognitive diffusion, that's we're bringing in, again, connected to mindfulness in a way, it's detaching from the inner experiences by interacting or relating to them differently. And so sometimes we know with our patients that an inner experience can be globalized, a negative emotion, a negative experience, feeling sad, down, depressed, hopeless, becomes a full global view that of perception that that person has, and may use negative self-talk to explain that. I'm a loser, I'm a failure, I'm just an quote addict, I can't get this right. Cognitive diffusion helps separate from that. And then acceptance. Acceptance is a shift in not fighting, but allowing thoughts and feelings. And this really connects to what a lot of you already know in motivational interviewing, where we really meet that cliche, meeting the patient where they're at. This really is what it's talking about here, that the thoughts and feelings are allowed to arise without trying to change their form or change their frequency. And again, acceptance builds emotional muscle and cognitive muscle to allow these experiences to be tolerated. And instead of creating obstruction and tension, we allow them to flow through, which really leads to true management, which is what we're really helping rebuild and recapture for our patients who are in recovery. And then in mindfulness, included in ACT is mindfulness, which is to retain contact with the present moment. So critical, so helpful for many of our patients that seem to get in that snowball effect, that whirlwind, where they can help themselves get grounded. And then self-understanding, letting go of concrete, inflexible thoughts. This is breaking the rigidity that many of our patients have, or their global ideation or ideas about how they view themselves, and moving to a sense of understanding with oneself. And really this brings in, I think, a lot of compassion, of teaching our patients self-compassion. We think of compassion as an innate skill set. It is not. It is something that we learn or have to learn if we want to utilize these effective interventions. And so it's okay to think about teaching compassion as a skill set that patients may not be too comfortable with, and bringing that in. And then values, our patients' values, learning and really helping our patients identify what's most important to oneself. Why is this so critical? Because we know from our motivational interviewing skills that this is really the seat of motivation and of activation, of behavioral activation, of what I value is what's going to motivate me to do things and to ultimately change. And then committed action, efforts to empower the behavioral change, those changes, those steps to make in the quote real world, moving to an understanding of oneself within that context. So critical. And so the CBT model, we're going to go over this quickly. Many of you are familiar with it from many of your other work in other different areas, but this is really how it applies to substance use disorders. And so the CBT model, the classic model is the ABC model, back from Albert Ellis, where we have A, an activating event, B stands for the behavior, C are the thoughts, the cognition, and then hopefully bringing in a D where we learn how to dispute some of those thoughts that generate potentially uncomfortable emotions. And so this is kind of how it works. This is a little bit of a linear view of it. For many of our patients, it happens more in a non-linear way, where we have a behavior, and that sometimes is associated with either using a substance or coming up with alternatives to using a substance, like maybe talking to a friend, going to a support group meeting, or a walk in the park. So we come up with alternatives to use. And then also triggers. So I'm sorry, situations. And situations are associated with triggers, and they're also associated with cravings, which we're going to dive into in detail. And also then how that connects with our emotions. And the way we think, we know, generates the way we feel, the way we experience things. And so the interaction of our thoughts and our emotions, that if we're thinking about maybe using drugs and alcohol, or are we thinking about, hey, this is a support group that can help me, and how this interaction all works together for our patients. And we're going to talk about how we can flush this out. And so this is going to be kind of our toolbox for today of using some CBT interventions. And we're going to talk about the 5 W's: quality questions, triggers and activators, psychoeducation, and then some red flag thinking. So the 5 W's, and this is kind of the who, what, when, where, and why. And it connects so closely to a lot of the work that's been done in the support communities, 12-step support communities. You hear this in NA and AA a lot, is people, places, and things. And those folks knew about people, places, and things, I think way before it was brought into cognitive behavioral therapy for substance use disorders, and they were totally on. That really helping our patients identify their activating events, their activating triggers. Again, remember our definition, maybe unbeknownst to them, that they need our coaching, they need our support to identify these things and flushing these things out. So identifying who are the people that are associated with their substance use. And that question, what does substance use do for me? Again, helping our patients come up with these answers. When, the time, is there a pattern? Is Friday night or payday? Are those the whens that I need to be really aware of, and that we need to help our patients identify and become conscious of, become aware of? Places. Are there places, neighborhoods that I need to be wary of, that I need to be mindful of, that I associate with using or buying drugs? And why? So why do I use? What am I experiencing? What am I feeling? And taking a list like this for patients, working with them, and this is simple, right? Creating a list of who, what, when, where, and why gives us an entry into helping and talking with our patients about getting to know and bringing their drug use into the session. And that's a healthy thing. We have to get away from banishing and pushing away these thoughts of drug use. No, we want to bring them in so that we can talk about them in a way where we can start to dispute them, the D in our ABCD model, and also come up with alternatives, alternative behaviors. And then our quality questions. And so these are great questions, again, to help us start to enter into and understand the pattern of use for our patients of what was going on before you used. And so using is an event, but taking that event here and tracing our steps back of what happened here, being able to look at that relapse event, that return to use event, as maybe step 3 or 4 in a relapse stage that started occurring way before that. And so asking questions, well, how are you feeling before you use? So maybe there was anger, you were upset, something happened. And maybe it's more about the place, that over here you found yourself, you didn't know how you got there, but all of a sudden you're hanging out in the park where you used to always buy your drugs. And maybe it's home that you've reached back out to some of those people that you associate and have used with in the past, or the event that happened. What was it, the activating event, and where were you when you started to think about using? Because there's so many opportunities that happen along that continuum before that opportunity of use that we can start to, and again, not a punitive approach, but building this skill set into our patients so that they start to gain of awareness of what seems like an automatic experience actually has probably many steps that happen and occur before a patient picks up a drug or a drink. And so triggers and activators, right? Looking at those triggers and activators that occur before use. Many of them are shared among people who have substance use disorders. However, many of them are personal. And helping our patients understand some of those personal relapse triggers can be so key. For an example, many people would agree that a shared trigger or activator can be being in a place where alcohol or drugs are being used or served. So that may be going to a dance club or a bar or a sporting event. That can be looked at as a universal kind of shared trigger or activator for many people with substance use disorders. A personal activator may mean something like going to sleep at night for some patients, especially patients who have a trauma history, that just actually starting to prepare and get ready for rest or sleep can be an activator or a trigger for substance use. And that may be very personal or unique to that individual person. And some of these are internal, that certain emotions or emotional experiences are a real struggle for some folks, that they may be internal triggers, that when I feel anger, say, that is a trigger for me to want to use alcohol or drugs. And then external are things outside of ourselves, like being at maybe a discord in a relationship, that those are external triggers. And so helping our patients identify their unique internal, external triggers really helps start to bring in awareness and consciousness to the day-to-day. And that is a mindful state that we can help our patients shift into. And it takes away the experience that many of your patients maybe say, I don't know, I just ended up there. I ended up using, I just had a drink in my hand. I don't know how that happened. And on some level, that's really true. They don't. On the other level, there's so much going on for many of our patients before that return to use, before that relapse event, that we have the opportunity to intervene. And that means in our sessions, looking back at those experiences, that history, that return to use, and using those as opportunities to help build this capacity can be so key for those individual relapse prevention plans. And so, talking about triggers and activators, there's 4 components to our triggers and our activators. There's behaviors, there's cognition, there's emotion, and there's cravings. And so here is our trigger. And to this concept that we're talking about is in these areas is an opportunity for us to intervene. So we have our trigger. And typically what happens is that generates a thought. We get triggered that we want to, whatever that is. We talked about the different internal, external triggers. And I have a thought. And my thought is, I want to use opioids. I want to get some oxy. And that thought then generates a craving, that I start to crave getting that drug. And then that leads to return to use or that relapse event. In each of these areas is an opportunity, again, for us to provide that life jacket, that opportunity as an alternative, that if we take what works, and we know that drugs and alcohol work, they work in each part of these areas. The problem is that they have dire consequences, that they have such negative consequences that while they work, they also lose their effectiveness. And so we want to replace those interventions with other interventions that are healthy and that work. So let's talk about what some of those can be. So behaviors. So behaviors associated with use. And this gets into our behavioral activation planning, that we can help our patients start to plan to engage in non-use behaviors. This means coming up with, again, connected to our values, what our patients really like to do, what inspires them, what energizes them, of coming up with different things that they can do as alternatives and non-using behaviors. So that may mean avoiding people, places, and things, but also paying special attention to nutrition. For many people, not taking care of themselves in other ways is a really good indicator that they are in that relapse mode that we talked about, that continuum. Same with sleep. When they leave a structure that you've come up with, a healthy structure, when they start to deny that structure, or they start to miss appointments, when they start to break from that alternative structure of health to leading out of that, is such a critical time and an opportunity for patients to become aware that they are in potential risk for returning to use, because that leads to those old pathways, those old neural networks of saying, yeah, let's use oxy, let's use alcohol. So some interventions for behavior activation is really giving patient homework. So following a planned schedule, coming up with a plan for patients who may not have had structure for quite some time, building in a structure that they follow, and recognizing and awareness around their activities, where they're going, what they're doing, the places that they are. Bringing in a lot of the skills that many of us already have for stress management, helping with stress management, helping with anger management, behavior activation planning. Those are skills that many of us have that we can bring into treating people with substance use disorders from other areas. And then making a list with patients. What are my high-risk situations? What are my low-risk situations? Making this aware, making this present, putting it on paper, making it tangible, having them keep it in their pocket. Again, that's helping support the science of what we know. Our work is really rewiring, in support with the MAT medications, the neural networking in the brain. So any skills that we can use to bring in to re-message this stuff is going to be so helpful. Maybe it's an index card. Maybe it's putting it on a calendar. There's a lot of different ways that we can help patients externalize and internalize this outside of our sessions with our patients. And so homework's really helpful with that. And so cognitive components. So this is really connecting that thought part of, am I thinking about using drugs and alcohol to help me manage this situation? Or am I maybe using some alternatives like a support group in the picture below? And we have our cartoon here. It says, I'm disappointed. If anyone should have seen the red flags, it's you. Certainly that is true for a bull who supposedly has an eye for red things. However, this is actually a myth that many of our patients, because of what's happened in the neural circuitry and neuroadaptions in their brain, they don't see the red flags. We have to build that back in for our patients. And so it's really starting to help patients gain that awareness and recognizing thoughts associated with use. So helping them build the muscle to dispute thoughts or thought stopping, to really call a timeout in their life. Sometimes that thought becomes a snowball effect, and teaching them the skill set when they start to speed up, when they are thinking quite a bit, that they can stop that process. They can call a timeout. And to gain an awareness to that. We start to see patients in the danger zone too, when they start to do what's called a reduction of options, where all the interventions that we come up with, they find themselves saying, well, that won't help, or this won't help, or that won't work, or I can't go there because it's raining out. When we can teach our patients that they may fall into a reduction of options, they can gain that an awareness to say, oh, wow, I'm reducing options. Because for them, that reality that it's not a possibility is very real. Again, using mindfulness, our CBT interventions, they can peel back from that and gain an awareness to say, I'm globalizing that thought that nothing's going to work for me. And in fact, that's not accurate. I can pull back from that. Some other danger cognitions that we need to be aware of, some flags that go up for us, is that, when we hear patients say, I totally got this, I don't have to worry about it, I'm never going to use again, I'm not even thinking about it. Those are, again, versions of globalizing a thought and can put patients in a risky situation, because they then can't utilize their interventions if they feel like they don't need them. And then the kind of opposite side of that is if a patient returns to use, they say, I used it, I blew it, so I might as well just keep on using, or use even more and more, and use that thinking as a way to catastrophize the situation. Same, we hear patients say, I'm hopeless, I'm helpless, I'm weak, I'm lazy, I'm selfish. And helping dispute patients instead of globalizing that view of themselves, looking at that thought, disputing it, and peeling back from it. And really shifting. A lot of times in addiction treatment, we come up with the word, and it's a carryover from our old way of treating addiction from a punitive standpoint of being responsible and building responsibility versus accountability. and helping our patients understand they're not responsible, that people with a substance use disorder, while they are accountable for their behaviors, if we go back to our definition, it's not their fault they have a substance use disorder. That changes have occurred in the brain. They've robbed the neural pathways. There's been adaptive changes in the brain. They're being compelled to use, not by their choice, but because of what's changed in the brain. Helping our patients understand that can so help reduce the punitive approach that they've received probably most of their lives from most of their interactions with healthcare, but even harsher so within their own self and their own self-talk. And again, shifting away from, I have no power, I have no control. Absolutely, you do have power, you do have self-control. These are skills that we can build in to help you flex that muscle. And then replacing those thoughts with pro-social positive thoughts. Again, bringing in our psycho-ed, understanding addiction is not a moral failure, helping build compassion, self-compassion with our patients, and that looking at failures as relapse not as failures, but as opportunities. Where do we need to look at? How can we bring this relapse event into our session and talk about where we could have intervened? Instead of pushing patients away and saying, hey, you need to come back to treatment when you're ready, when you really want this. No. Relapse is an opportunity for more care. And again, it's bringing in that ACT component of self-understanding. And then red flag thinking. When we hear our patients, again, we talked about some of those cognitive distortions, but when we hear absolutes, I'm hopeless, I'm helpless, there's nothing I can do. When we hear black and white thinking, I'm forever going to be a quote addict. I don't use that language. It's derogatory. Some people in recovery do use it. And so that's why I put in my air quotes here. But that black and white thinking, helping shake that view from our patients is so helpful. Also, patients discount the positive. Using our MI skills is so critical in this component. Where, asking a patient on a scale of 1 to 10, how motivated are you for change? And they say 2. And you say, great, why isn't it a 1? Tell me what's going on in there. That patients helping them remap to the positive is so critical. We see our patients sometimes jump to conclusions. They do things like mind reading, fortune telling, and also self-blame. Critical components that we can help shake our patients out of using our CBT skills. So being aware of those red flag thinking. And then our negative emotions, helping patients manage and build emotional resiliency. Moving away from thinking of emotions as negative or positive. And we use that terminology as the ones that don't feel so good and the ones that do feel good. And that's okay. I think it's a good way for us to talk about it, but really getting away from the idea that negative emotions are bad. They're not bad. Anger is a healthy, normal emotion. And helping our patients to pull anger in rather than fighting and resisting it can be so helpful because it builds emotional resiliency. And then we aren't dependent on things outside of ourselves to help manage our anger. We can help manage our anger or whatever emotion it is internally. And so building that and bringing that capacity in and reminding our patients that feelings, they're not always proof of the truth. That it doesn't mean that you're right, but it does mean that you feel that way. And that it's okay to validate those feelings, that they are real, they are present, but it doesn't mean that it necessarily means that you're right or that you're truthful in your assessment or your judgment or whatever it is, the way that you're thinking. So it's okay to have those thoughts. And I think that's where ACT comes in that acceptance modality a lot, that allowing those thoughts and feelings to arise. Sometimes, and especially, we used to get nervous around, especially patients with substance use disorders, that if they get angry or if they get whatever way that they're going to use, well, that's okay if they get angry. We want them to, especially with us in our offices, to help build that emotional capacity. And then our some quick tips here. So teaching patients, again, connected to that emotional capacity. that the body in so many ways knows better than the mind. Helping our patients understand and identify emotional experiences in their body can be so helpful. Many of our patients, they don't know what they're feeling. In fact, they use their mind to tell them that they're not, which brings them out of alignment. When you have a patient in your office and you ask them how they're feeling and you see something like this, those of you that can see me on the screen, ask me how I'm feeling and I say, I'm fine, I'm great. Well, no, that's I'm out of alignment, right? I may be telling myself not to be angry or not to be rigid, but I am certainly looking and appearing and experiencing that way. So helping our patients understand that when I tighten up, when I squint my eyes, and when I get a headache, a backache, a neck ache, a stomach ache, those are body signs for me to help teach me what it is that I'm experiencing on an emotional level in my body. So teaching our patients to trust their gut. Many of our patients have used substances to get them away from those experiences, bringing them into them and starting to help them experience them in safe, healthy ways reduces that need and dependency on substances to take them out of it. And so mindfulness becomes our eye of awareness, of using our mindful approach that anchors us in our room to get in touch with our emotional experiences. So some body signs for some of our patients may be speeding up, moving fast, or getting stomach aches or increased energy. Or some of our patients even that may have the appearance that they look when they use the substance of choice that they use, that they may appear intoxicated in some way. Those are body signs to help patients understand that they may not necessarily be in touch with an emotional energy that certainly needs attending to. And then number 4, managing cravings. So we used to talk about resisting cravings and fighting cravings, and really what we're moving into now is managing those cravings. And using things like behavioral activation. So using those non-drug related activities to help manage when our patients are experiencing those cravings. And a key component for cravings is not managing it on your own, but taking cravings, not talking about cravings as a failure if you have them, but owning that, hey, I have this, and externalizing it. And it's the externalization of this internal experience of a craving that helps many of our patients free from this experience, not fight it, but manage it and release it, let it go by holding cravings close. And a lot of folks use the concept or metaphor of surfing the craving, that if they ride the craving, it goes back to this too shall pass, that this will flow through you, that you can survive the craving without using. In fact, by not resisting it, by bringing it close, you can use the skill sets that you build with the patient, some of the techniques that we've already talked about today, to help them manage and make healthy choices around that. The other thing that's really helpful is to help build a measurement tool, to measure with your patients, build a language with them to measure severity of craving. And it's not complex. It's measurement-based care using a Likert scale of 1 to 5. 5 being the strongest craving you ever had, 1 being more mellow. And it creates a common language of communication for you to help talk with your patients to understand that severity and intensity level. And you can even start to line up this craving level with some of the interventions that work best for that patient on an individualized level. So it's committed to action, right? From our ACT concept in managing our cravings, that it's efforts to empower behavioral change and moving to an understanding of oneself so I can make those changes. So I can make a healthy choice, understanding what it is that I'm experiencing, understanding and bringing that craving into that moment is going to empower me to make some healthy choices and to support my recovery. So partnering with our cravings, asking our patients, how do we do this? Well, a simple way you can do it in session is to ask our patients to think about a time when you were craving. Bring it into the session. Think about it in the past. Make a body sensation list. Where was it that you felt that? What were you feeling? Make an emotions list. Make a thoughts list. Break this out. Again, our patients need to externalize this stuff. We're helping rewire and remap that stuff that they may not be aware of. These kind of homeworks, this kind of in-session learning can be so helpful for our patients. And so we can break this down. This is a quick tool of that can be done any place, anytime. It's bringing what we talked about today into 3 columns, bringing that activating event of people, places, and things, the 5 W's that we talked about, and then having our patients kind of list those things. And then listing their beliefs, their thoughts, their emotions, their behaviors. Again, building that awareness. So what did you tell yourself? What were you thinking? What were you feeling? What you were experiencing? Bringing that awareness in. And then what were the consequences? What were the behaviors? What were the feelings that you had? What did you do? What did you not do? Bringing these pieces together help build in an easy way, but so critical and so important, a construct for our patients to use. And you don't need a special form for this. Again, you can download the PowerPoint slide and print this out, but this is something you can do quickly on any piece of paper. The patient can walk out with it from your session, and you can do it relatively quickly in your primary care setting. So this is going to kind of bring us to our tail end here. Just some friendly reminders, and then I think there's some questions in the chat that I'm excited to get into, and hopefully get into some discussion for our last 10 minutes here or so. But some friendly reminders: this webinar and our part 1 is also available for you. This is the link to get those. There will be a questionnaire. It's 3 questions. It's a checkbox. I really love it if you could fill that out for us. We love the feedback. We know you don't have so much time, so it's built to do it quickly. And again, my name is Nick, and so this is an easy way to get in touch with me. You can email me or shoot me a text or call. We do love feedback and hearing from you. Some of the other work that we do at NSI Strategies is really helping support you, the work that you do in your integrated care environment. So we focus, this is our website, and some of the things that we focus on: helping implement MAT programs, but also evidence-based care like SBIRT, and really helping raise your level of integration in the health centers that you work in. So if you think we can be of any support or you have any questions, please don't hesitate to reach out. We do a free consultation hour with you or any of your teams if you want to do that. Happy to do that. So we'll go ahead and look into the chat to see if we have any questions here. It looks like we do. We have a question from Sarah. It says, I'm having trouble addressing polysubstance use with patients who are stable on Suboxone. Great question. How do you reinforce sobriety from opioids while continuing poly use? Sarah, this is a great question. And I think programmatically too, operationally, a challenge for a lot of organizations out there. Our prescribers a lot of times get very anxious when they're prescribing Suboxone and patients are coming up with positive drug screens for marijuana or cocaine, methamphetamine use. And so the way I would answer this question is really that we have to think about having individualized use. And if you have a patient who's on Suboxone who has stopped using opioids, that is fantastic. That is a huge win. And so working with our patients in a way where we can start to talk to them about starting to reduce some of that other use is so critical and so individualized. So the first thing that I would say is if you're not kicking them out of treatment, great. That's the way to go. That, our old mentality is that if patients are coming up positive, we need to boot them out of treatment and kick them out of treatment, which hopefully sounds crazy because they're doing exactly what, according to the ASAM definition that we looked at earlier and the DSM criteria of addiction means. They're continuing to use despite negative consequences. They're continuing to use even when they don't want to. And so bringing our patients in even closer can be a really important way of helping support our patients who continue to use other drugs and other alcohol. And so some of the things that health centers have implemented is that encouraging those patients that if they want to remain on Suboxone, that they're going to need to work with that health center to address some of that other substance use because of the dangers associated with other drug use and being on the medication that they're on. So it's a great time to bring in the prescribing provider and you to do an integrated care visit together so that the doc can talk about some of the dangers from the medical component and you can talk about, as a behavioral health provider, some of the things that you think you can do to help support them reducing that use, to address that use. And so that can be a great way to start to come from a more harm reduction approach rather than an abstinence only approach which we know is just not effective for so many of our patients. So Sarah, thanks for asking that question. I hope that gets to the spirit of what you were asking. So great question. I think Vincenzo asked, if I'm saying your name correctly, how can the first step about being powerless be reconciled? And it's a great question, and I'm so glad it comes up, because sometimes some of the things that we talk about almost seem in contradiction with one of the greatest, best supports that we have, which is the 12-step community. And for many of our patients, it's an incredible support group. Some of our patients not so much and don't like to go to those support communities. So we need to remain open and individualized for what the patient truly wants. But Vincenzo, to answer your question, I think that our role as a provider, we can start to help them with some of the components of what is said in the serenity pair, of what I can control, knowing what I can control, and knowing what I can't control, and the wisdom to know the difference between those things. Some of the things that we are powerless over is our emotional experience. Once we have anger, once we experience an emotion, we can't use our mind, our thoughts, which is what generated that, to change it. We have to, if we want to, following the spirit that we talked about today, if we want to attend to that feeling, we have to surrender into it. Well, that's what we're talking about, allowing it to be. And that empowers us to take control and make choices of how to attend to that in healthy ways. And so it's not linear. We're almost talking about this in two ways at the same time, where it's both dynamics converging, where we're empowering ourselves to make healthy choices and to do the things that we know are going to be healthy to support our recovery plan, and surrendering into the things that we can't control. Some of the life circumstances that our patients experience, the social determinants that they have to face. There is not too much that sometimes we can do to impact those things. And so taking away the resistance and the fight, and allowing and understanding that sometimes we have to surrender into those things, creates a harmony in that area. And when we can help our patients find that harmony and that peacefulness in those things, we really can bring a lot of self-compassion and care and help support that personalized recovery plan for our patients. So thanks so much for the question. I think we're coming up right on our end. I know all of you probably have appointments to get to at 1 o'clock. Vincenzo, good. Thanks for the thank you. It sounds like I came close to answering that question. There's some other questions come in. I can go ahead and stick around and answer those. Folks that need to drop off, we understand that you need to do so. And if you want to get the recordings and the PowerPoint slide deck, please visit the website. You'll be able to download those. Those will be up in a little while. We'll also be sending an email out. Charlotte, thanks for your feedback. Charlotte says it was a great webinar. Thanks so much. Appreciate it. Harold's asking a question here. Most of my chronic opioid, benzo, muscle relaxer, amphetamine users have been getting a monthly prescription for their drugs from their previous medical providers. So in a sense, their triggers are current contact with the healthcare system. Great point, Harold. Tapering is appropriate but difficult, even with behavioral health support. Maybe a public health approach would work best, stopping production of these drug use. Harold, great. This isn't really a question from Harold, but a great point. And you answered, Harold, where I thought you were going to go with the question. I agree. It is a public health approach. And your first point, especially for those of us as health centers, FQHCs, so typically we hear about it. Patients get dumped into the FQHC because they run out of options. It's the only place that will see them. And I think that's great. I know the burden that puts on. I know the way I felt when I was working as a director in FQHC, the pressure that puts on, but it's an opportunity for us to truly help support the community and start to change start to impact the prescribing practices in our community. And so bringing these patients in, and you know, the one thing, how about this is to remember, these cases seem so big and require so much time. But the great part about being a center of health for these patients is they will come back. You don't need to fix it today, and you don't need to fix it tomorrow. These patients that come in with such complex dynamics, we have time because now they're part of our healthcare system, and wrapping them around with all the supports, the patient-centered medical home, is a way to look at the long game instead of the short game that we get so stuck in healthcare. So, yes, so Gail's asking about posting the slides. Gail, those slides are available in our nsistrategies.com website. You can go and download those, and you can also listen to the recording. Those are all available to you. Sheila is asking, how much success are we having using these new approaches? Well, Sheila, it's a hard question to answer in terms of how we measure success. The way I'll answer that is I think that a lot of the old way that we used to look at success was abstinence and sobriety only. And we looked at returning to use or positive drug screens as failure. And that's not the way we treat any other chronic health condition. We don't look at our patients with diabetes who come in and say, hey, I fell off my diet plan, or that come in and say, I haven't been exercising the way that we've talked about it. We don't look at those patients as failures. We don't take away their insulin and say, come back to care when you are good and ready and willing to commit to getting better for you and your family. We don't talk that way. And yet we brought that approach in to how we measure the success of substance use disorders. And so in that shift, especially with the impact of using MAT, medications to treat opioid use disorder, we have been successful. We've seen the death rate, especially associated with prescription pain medications, decrease. We've seen a decrease in prescription pain medications. Unfortunately, the death rate has also increased associated with illicit heroin use because, you know, back to Harold's point, we don't take a public health approach to treating substance use disorders. And so while reducing supply in prescription pain medications, we don't address the addiction piece of providing support for those folks. And so they're required to go to the street to get illicit drugs. And so we need to fill that gap that is so critical to help really impact our communities. So I'm gonna go ahead and wrap up on this question. Thank you all for attending. Please, if you have any questions or wanna reach out directly, love to hear from you all. You can email me at nick@nsistrategies.com or my cell phone. And again, thanks so much. We appreciate. And and our next webinar is going to be June 12th. You'll be getting an email for that. It's going to be focused on using motivational interviewing skills to impact health outcomes. So how we can better utilize behavioral health to treat chronic health conditions like diabetes and hypertension. So again, thanks everybody. Hope everyone has a great day, and we'll see you all again soon.